Okay, let's go ahead and get started. Thank you all for joining us today. This is the first Neonatal Hemodynamic Research Center site presentations. So the aim for this series is really to provide a forum for sites within the Hemodynamic Research Center to present their topics of choosing related to neonatal hemodynamics, such as interest in cases, protocols, or ongoing research at their institution. The aim is to do this every other month, with alternating with the Pan American Hemodynamics meetings, so that we'll have a talk, some kind of presentation with panelist discussion each month. So today, we're really excited about the topic today. Dr. Daniel Ibarra Rios is going to talk about his center's experience on neonates with COVID-19. Dr. Rios is a staff neonatologist at Hospital Infantil de Mexico Federico Gomez. He trained in T&E at the Hospital for Sick Kids in Toronto and leads the targeted neonatal echo and point of care ultrasound program in the NICUs there. Dr. Barr's research interests are in hemodynamically critical neonates, integrating cardiopulmonary physiology and functional echo. He's also interested, as you'll see from this presentation, in lung and head ultrasound of the critically ill neonate. Following his presentation, we'll have a Q&A with additional panelists. And joining us today is Dr. Jennifer Burmick, a neonatologist at the University of Iowa Stead Family Children's Hospital. Her research focuses in neonatal immunology with a particular interest in how early life inflammatory exposures impact development of the immune system. She uses both human and samples and animal models. And additionally, we'll have Dr. Gabriel Altit, who's a neonatologist at McGill University and Montreal Children's Hospital, who has extensive training in echocardiography scanning and in research. He created Cardio Lab as a resource for neonatal hemodynamics and launched the Neonatal Hemodynamics Clinical Research Fellowship at McGill. So I would like to introduce Dr. Daniel Ibarra Rios. His title of his presentation today is on cardiopulmonary dynamics in newborns with COVID-19.
Good afternoon and good night. Thank you so much for letting us share with you our results with COVID in Mexico City. We're going to talk about cardiopulmonary dynamics in newborns with COVID-19. I'm Daniel Ibarra. I work in Hospital Infantil de Mexico Federico Gomez. And you can see here Ixtlilton, which is the Aztec god of children. And I don't know what you guys think, but to me, this is a proof. It's a big proof because it was Aztec times. I want to acknowledge Dr. Horacio Marquez Gonzalez from the Clinical Research Department. He's a brilliant cardiologist and researcher that has helped us a lot with our ultrasound projects. Our colleagues in pathology that gave us a lot of the images you will see. And the most important ones are our neonatology fellows, which have courageously acted during this pandemic with a lot of professionalism, and we owe them a lot. The virus came to Mexico, and the first case was diagnosed February 27, 2020, and it was a patient who traveled to Bergamo, Italy between February 16 to 22, 2020. And analyzing the virus, it is thought that it traveled from Belgium, then England, then Italy, and finally to Mexico. To the first week of November 2021, we have 3,818,216 cases with 289,131 deceased patients. And regarding pediatric population, infants less than 1 year has shown a case fatality rate of 2.1%. We're a tertiary level referral hospital that is 2,240 meters above sea level. We have 229 census beds and 120 non-census beds, and we were reconverted in order to receive pediatric COVID patients. So as we're a T&E crowd, let's do a quick overview of lung ultrasound. So here you can see one rib, another rib, and the pleural line that it's sliding. It's very important that you see lung sliding, otherwise you might have a pneumothorax. And we use the bat sign to identify this space, which the ribs would be the wings of the bat, and the head of the bat would be the pleural line. It is not so clear in the anterior fields as the newborn don't give posterior shadow, but when you see lateral and posterior fields, it's a bit clearer, the bat sign. So the normal thing is to have normal lung sliding and A lines that we will see. And we can do the cut either longitudinally or transversally. If you do it transversally, you will go intercostal space by intercostal space, and also you can sweep from the head to the feet. And if you have a normal lung, a normal aerated lung, you will see lung sliding, and you will see the reflection of the pleural lines, which are the A lines. So a normal lung has lung sliding and A lines. When you have air and liquid interface, you get the ring down effect. So emitted waves from the resonant vibrations within a bubble tetrahedral complex creates a linear artifact in the axis of the insonated ultrasound wave that starts from the point of origin and rings down to the end of the screen without fading. And that gives us the B lines. So the B lines is a specific term for the ring down effect we found in lung ultrasound. It originates at the pleural line. It has a strong light rate appearance, obliterating other background lung ultrasound artifacts, especially the A lines, and it moves with lung sliding. And when you have a consolidation, here you're really looking at lung parenchyma. We normally don't see it because we have air or air and liquid interface, which we identified as artifacts, but when you have a consolidation, you're truly looking at the hepatized lung. So here you have the liver, here you have the diaphragm, and here you have the hepatized lung. And I superimpose the image here at the X-ray just to give us a little bit of idea of what we're seeing. And these are the regions that we normally explore. So classically, in all the studies that have been reported, you study 6 areas: anterior superior, anterior inferior, and lateral right and left. But when you're looking for consolidation, it's really important to look at the back of the patient. So we used 10 areas scale that I will show you posteriorly, and you can see here depicted on a baby. And a semi-quantitative scale, the idea is to put a number on what you're seeing. So you have a normal lung, it would have 0 points, and you have lung sliding and A lines. If you have B lines, more than 3 B lines, you would have a black and white appearance, and it translates as interstitial lung edema, mild to moderate. If these B lines coalesce, you can have a white lung, and that translates as severe alveolar interstitial edema. And when you have a consolidated lung, well, you're truly looking at the lung, and we would give them 0, 1, 2, or 3 points. And here you can see the semi-quantitative score that has been used in a lot of studies. And basically, it really correlates well with computed tomography, which has been proposed as a standard of image during the COVID pandemic. It correlates well with Silverman-Anderson. It correlates really well with oxygenation, and also correlates well with inflammation, both in human and animal models. You have a higher score with more respiratory difficulty, worse oxygenation, and more inflammation. And here's the scale we used, giving 0, 1 point if you have more than 3 B lines, 2 points if you have white lung, and we gave 3 points if you have consolidation, but we also considered if you have pleural effusion that was reported in some series. And as we had a patient with a diaphragmatic hernia, also if we look at bowel, well, there's no air there. And here you can see a normal A pattern with lung sliding and A lines, or a B pattern. Here you can see separated B lines, but also B lines can coalesce and give us a wide lung appearance, or a consolidation that were classified as small when they were less than 5 millimeters, or big when they were more than 5 millimeters. So what's on the literature? Feng and colleagues in China described 5 cases, 1 to 18 days, and the abnormal findings was an abnormal pleural line, B-line interstitial alveolar syndrome, and a small range of pulmonary consolidations. And on follow-up, lung ultrasound improved according to patient status, and all babies were discharged. Then Giorno and colleagues in Brazil did this series. This is a pediatric series, but it included 3 newborns, and one had a computed tomography. And as you can see here, it correlated well what you can see on the tomography and what you can find in the lung ultrasound. Then there were some case reports in Spain. Pineda Capilur reported this Baby had an horizontal transmission in a 10-day neonate, and long ultrasound revealed pleural thickening, converging V lines in the posterior chest, and subpleural consolidation at the lung base at the level of the right hemithorax. And then Gregorio Hernandez reported 3 patients. All 3 patients had some other neonatal disease, severe hypoxic ischemic encephalopathy, a premature baby now with BPD, and a Hirschsprung disease. But they also did a semi-quantitative scale and followed the babies through their course. All 3 babies were discharged, and also a B-line pattern, consolidations, and abnormalities at the pleural line. Then in Brazil also, Matsuka and colleagues reported this study. This is sort of a pictorial essay. So we have 3 groups: babies without COVID and respiratory symptoms, and babies with COVID with and without respiratory symptoms. But the problem is we don't know the number of patients per group. But the conclusion of this study is that they found similar images between groups, concluding that long ultrasound was efficient in evaluating COVID-19 related changes, as well as pathologies inherent to the neonatal period. And finally, in China, Li and colleagues did a case-controlled study. It's 11 babies per arm, and they analyzed 12 regions, and they also did a semi-quantitative scale. So compared with controls, COVID-19 neonates showed a sparse and confluent B lines, disappearing A lines, an abnormal pleural line, and consolidations. And the long ultrasound score was significantly higher in the COVID-19 groups. Most of the lesions were in the bilateral inferior and posterior regions. So when we started receiving babies with COVID, the safety of our personnel was the most important thing. So we tried to follow a strict protocol for personal protection. We have a special area in our hospital where all the babies that are admitted are suspicious babies. And once confirmed, we have another more isolated area for confirmed cases. And we started doing ultrasounds with a portable, affordable probe that connects via Wi-Fi to an iPad. And you can do this either yourself or you can take images at distance, as I'm showing you here in this video. There was a lot of publications praising the use of long ultrasound, so we give it a shot. So the baseline study was performed with a handheld device in 88% of cases, 28 patients. And if the baby needed an hemodynamic consultation or a head ultrasound or a cardiology consultation, we dressed the machine according to what was reported on the literature. So in our study, the studies were done by a single operator in 69%, image acquisition at distance 28%, and by a trained fellow on 3%. And again, the most important thing was our personal safety. Unfortunately, we didn't have any case related to ultrasound. So from April 2020 to October 2021, we received 38 patients with a positive RT-PCR. 6 of them were briefly in our hospital, so they were discharged without oxygen. And then we have 32 patients, so 81% had a long ultrasound. And from these patients, 13 required an hemodynamic consult or point of care consult. So 6 babies were previously known, so we have an internal outbreak, and 7 patients were first time. 2 of them required also a cardiology consult. From the babies that we previously knew, 4 had history of IBH, and 1 baby had severe bronchopulmonary dysplasia and unfortunately died. I will show you that baby posteriorly. And from the first time point of care or hemodynamic consult, we have 2 large PDA with pulmonary hypertension, 1 developed non-hemorrhagic dilatation. We have 3 patients with pulmonary hypertension, 1 with a congenital diaphragmatic hernia, asphyxia, and a large hyperechogenic lesion, and 1 with a big cerebral lesion, categorized initially as grade 4 IBH, but it's not like that. I will show you that patient later. And 1 baby with perinatal asphyxia who had a pattern of near total asphyxia, and 1 baby with esophageal atresia, partially anomalous pulmonary venous return, and severe pneumonia who received a cardiology and a point of care consult. We also had a septum pellucidum agenesis, corpus callosum hypoplasia, and also unfortunately died. 15 patients received follow-up, 7 were discharged without oxygen, 7 with oxygen, 8 without oxygen, and 12 patients were quickly discharged or transferred to other service, 2 with oxygen, 9 without oxygen, and 1 baby was transferred to another service. And this is an example of how we put the note in the patient's chart and how we calculated the semi-quantitative score, and if we give a recommendation. 53% of our patients were female with a gestational age of 36 with interquartile ranges of 30 to 38. Infection occurred at corrected age of 38 with an interquartile range of 33 to 41%. Regarding mode of transmission, we used the classification proposed by Dr. Prakesh Shah in Mount Sinai. So for us, it was a possible congenital infection, 6%, possible neonatal infection acquired intrapartum, 3%, and 91% were neonatal infection acquired postpartum, from which 30% were community acquired and 60% were acquired in the hospital. And the patient baseline diagnosis, 41% were preterm infants, term infants with respiratory distress, 28%, 25% were surgical patients, one patient with a congenital diaphragmatic hernia, and 81 of the patients were classified as respiratory patients upon arrival. Our findings were, we found a B-line interstitial pattern in 90% of the babies, an irregular interrupted or thick pleural line, 88%, compact B-lines, 65%, small consolidations, 34%, and extensive consolidation, 37%, and consolidations showed a posterior predominance. And you can see here abnormalities in the pleural line, a B pattern, a wide lung, and small and large consolidations. And after consultation, the recommendation to the attending team was pronation in 41%, an increase in continuous or positive end expiratory pressure on 34%. Patients were evaluated in mechanical ventilation 47% of the time, indirect oxygen 25%, CPAP 6%, high frequency ventilation 9%, and 13% without oxygen. As you can see, the lung score was higher as the mechanical support increased, being higher in patients with mechanical ventilation and low with patients with no support. And as the babies improved, also the lung ultrasound score improved, taking into account that all of our babies had also some other neonatology, surgical, cardiology issues. And when we analyzed the relationship between the lung ultrasound score and the FiO2 that was needed at the time of infection and at the basal assessment, we found a linear positive correlation. And here you can see the babies that unfortunately died. So we have a positive correlation that has been shown also in other studies regarding oxygenation. And when we analyze patients that survive and non-survivals required more FiO2, and as you can see, had a higher semi-quantitative scale. So we're going to see some cases to illustrate. This is the first case, and you can find this case as the first case report in the NHRC website. This is a 3-kilo male infant born at 40 weeks. Born from a 20-year-old gravida woman with history of type 1 diabetes, mellitus in control with insulin. She had irregular follow-up with normal second and third trimester fetal ultrasound. And during labor, fetal heart rate showed late decelerations. An emergency cesarean section was made, no late cord clamping, Apgar scores were 8, 9. And when the baby was intubated at the third day of life, the cardiologist from that hospital called us because he had some concerns. So after transition, the baby started desaturating, required oxygen hood, CPAP, and then the baby was intubated. And on day 3, we had the positive PCR for COVID. So the baby was intubated, and if you see the X-ray, you will clearly think maybe of a cardiac disease. The echo showed us enlarged right ventricle, and the baby had a large PDA. This PDA was bidirectional, and the cardiologist, the Dr. Martinez from that hospital, was concerned that when that duct closes, the baby might have some left side obstruction. Remembering where the ductal tissue normally is, and that it's difficult to assess a coarctation in the presence of a large duct. So the baby at first had pulmonary hypertension, a flat septum, and you can see the EA ratio that when the duct became left to right, changed. There was nothing impressive on admission labs, maybe mild thrombocytopenia, but nothing else. And you can see here in the lung ultrasound, if you analyze the anterior fields, there wasn't not much, maybe a mild interstitial pattern. But on the posterior fields, you could see the consolidations. So here we have a longitudinal image. And here we have a sweep from head to toe, where you can see intercostal space by intercostal space on a transversal sweep. And also you can see the consolidations. So the baby had one asymptomatic hypoglycemia that was managed augmenting glucose infusion rate. He was prone, we increased PEEP, and we were able to lower the FiO2. And as oxygen was weaned, we postponed the first echo and cardiology assessment of the arch. Here you can see with the portable probe that we can see the tooth in its place. And then with the echo, we can see the tip, the endotracheal tube position. The baby had a small PFO, left to right, and there was nothing important in the cranial ultrasound. So the infant was kept in an incubator, no antibiotics, blood cultures were negative, mechanical ventilation occurred for 6 days and 3 days on CPAP and 3 days on supplemental oxygen. Biventricular dilatation was managed with diuretics, and at day 20, we had a 1.9 millimeter non-hemodynamically significant duct, and the baby was discharged. And you can see on the control ultrasound how you have a more normal anterior. And in the posterior fields, you can also see that we have some B lines, but we don't have consolidations anymore. Small ductus, restrictive, and the baby was discharged. Unfortunately, we lost follow-up of that baby. Here you can see the arch without any obstruction. And as time passed, we were able to have the pathology exam of the placenta of this baby showing histopathological changes that has been reported for COVID with fibrous sclerosis of the great vasculature and inflammation constituted mainly by macrophages. And when they did a real-time PCR, they were able to amplify the viral E gene in the placenta. And when the baby returned at 1 year of age, you can see cardiomegaly, and also you can see an enlarged thymic shadow that we will mention posteriorly. And the baby was transferred to cardiology and is listed for device closure of a big PDA. Interestingly, another RNA virus that gives you a tubular PDA, it's rubella. So it's just a coincidence, but it's important to take into account. And regarding immune response, it has been told a lot that maybe the T cell response in the newborns is important, and that's why it doesn't progress. And normally you have mild infections. 26% of our discharged patients showed an enlarged thymus. When you're doing a lung ultrasound, you always find the thymus, and it's important that you recognize it. You don't confuse it for a consolidation. And in babies with an enlarged thymus, either on ultrasound or in X-ray, we measure the thymus, finding an enlarged thymus when you compare it with what's reported on the literatures. We don't know what that means. We only think it might be a marker of adequate response to the infection. This is another case, 39 weeks, congenital diaphragmatic hernia without prenatal diagnosis. Transferred on the first day of life to our hospital, severely sick, mother with history of drug use, cocaine and derivatives, with perinatal asphyxia. On day 2, they had a really high D-dimer, and the positive RT-PCR for SARS-CoV-2 was taken, and the baby was positive. So we have a really high D-dimer, low fibrinogen, and coagulopathy. The baby was started on milrinone and norepinephrine. And when we received the baby, we were working by shifts. It was impressive that the baby was on 80% FiO2 with saturation of only 85%, and we had a NIRS of 95%. And you can see here it was when we received the baby in its worst moment. So the first thing we did was a head scan, And we found this big hyperechogenic right side lesion. But the mom had story of drug abuse. Also, we had perinatal asphyxia. When you see the Doppler, it carried out bad prognosis. And we've all heard the fantastic Neil Patel approach to and talks on diaphragmatic hernia. We use a lot of those concepts, taking into account the left ventricle performance. Here you can see the autopsy of this baby. And this baby had a completely right to left ductus arteriosus, but a left to right PFO. So that means that the pressure at the end of left ventricular diastole exceeds right ventricular pressure with abnormal left ventricular filling and an elevation of pressure on the left atrium. So these babies needs to receive drugs like milrinone, and we should avoid nitric. Here you can see the big PDA on this baby. The baby had right ventricular dysfunction with a low right ventricular output. Here you can see the right ventricle in the autopsy specimen. And the baby had a really deficient left ventricular performance with symptoms of 40% and an LVO of 67%. So this baby was a candidate to ECMO, but regarding the history and the central nervous system lesion, it was not a real candidate. Gigantic RV with a SID score of 5.2 and elevated pulmonary vascular resistive index. And when we entered this patient's data on the calculator of Focus Neo, you can see how it helps you to identify a baby with very low cardiac output and critically low oxygen delivery and fractional oxygen extraction and high systemic vascular resistance. So our consult was, our approach was to adjust milrinone, diminish and stop norepinephrine, try dobutamine if no improvement, avoid nitric, and we reported the extensive, possibly ischemic lesion with bad prognosis. We did a neurology consult, and we also present the patient for palliative care and adjust fluids. As you can see, we also use ultrasound to see foreign objects, the endotracheal tube and the catheter in order to adjust them. And we can see in this case what has been reported as important features of lung ultrasound on diaphragmatic hernia with partial absence of the hyperechogenic line that represents the normal diaphragmatic profile, partial absence of pleural line in the affected hemithorax, absence of A lines in the affected area, and presence of multi-layered area with a hyperechogenic contents in motion, which is the normal gut, and possible presence of parenchymatous organs inside the thorax. This is an article by Dr. Yuri Corsini. And when we did the lung ultrasound score on this baby, we had a really high lung ultrasound. You can see here the herniated lung was really hypoplastic and it was totally collapsed. And we confirmed that in the autopsy. And as complications, this baby had a pneumothorax not picked up by lung ultrasound, but by X-ray in its follow-up. This baby unfortunately died. And when they did the autopsy on electronic microscopy of the affected lung, they were able to identify these images that are compatible with the coronavirus. And to finish the cases, I'm going to just show you a last case regarding central nervous system involvement. This is a 32-week baby. Mother and baby were positive in less than 48 hours. And this study done on the second day of life, you can see that the baby had a large central nervous system lesion and also a pneumonia consolidation. The baby had moderate pulmonary hypertension. And we did follow up of this lesion that is not classic IBH. The baby was a 32-week baby. So I think it might be related to COVID. And you can see on follow-up, this baby is now being followed up in our clinic. But it's an interesting case because it also had very early central nervous system involvement, and you cannot classify this as normal IBH. So trying to conclude, the placental involvement is really important. So it has been shown in studies that when you have severe placental involvement, it can definitely has an effect on the newborn, irrespective if there's vertical transmission or not. That has been a controversial issue. And that can give you an altered transition. But also you can have a susceptible newborn in the NICU, and after COVID infection, you have direct lung injury, lung edema that works as acute RIOS, hypoxic vasoconstriction. The thrombotic component in the newborn is not that clear, but it's really it's normal in adults. You also have the side effects on ventilation, pulmonary hypertension, ventilation perfusion mismatch, and you can also have superimposed infection, inflammation, and endothelial dysfunction. That gives you right heart dysfunction, and then you can have also left heart dysfunction. And also in the heart, you can have direct cardiac injury, myocarditis, possibility of arrhythmias, inflammation, and endothelial dysfunction, the possibility of infarction, and also septic and drug-induced cardiomyopathy. And as concluding thoughts, the lung ultrasound patterns we found were like the ones described in other series, neonatal and pediatrics. 88% of studies were performed with a handheld affordable equipment, so it can be used to screen babies and to classify them. And while there's no specific pattern and it varies according to gestational age and baseline diagnosis, lung ultrasound showed to be useful to assess lung involvement and correlated with FiO2 needs, was higher in patients who need ventilatory support and decreased with patient improvement. And all the diseased patients had a higher lung ultrasounds and FiO2 needs, and all the patients that died needed either hemodynamics or cardiology consultation and had comorbidities, and 26% of discharged babies showed an enlarged thymus. Thank you very much for your time, and let's start the panel.
Thank you very much. Daniel, if all the panelists could show their video. Daniel, that was a really great presentation. Thank you for, I should do Joe also. Thank you for putting all that together and for showing those cases. I was interested in knowing, so when you do your lung ultrasounds and do a hemodynamic consult, do you repeat the hemodynamic consult or do the echo again after you've made changes based on lung ultrasound? Or based on hemodynamics?
So the idea was to use the portable probe in most cases, and only if the baby clinically needed some hemodynamic consultation, we dress the whole machine. All the babies that we evaluated had mild pulmonary hypertension, and most of them responded with ventilatory measures. So we did the follow-up once the baby was negative and in our general NICU.
And thank you. If any other questions, please put them in the Q&A. Gabriel?
Daniel, thank you so much for such a great presentation. It's really nice to see that you can share some of your experience, because as these cases are piling in different centers, I think more knowledge is going to be needed to be shared among every practitioner so that we are best at treating these babies. I'm wondering, in your experience, they describe a lot this inflammatory pattern in some of the adult cohorts, and there's a large place at early instauration of like dexamethasone, for example, for pulmonary inflammation, which we know also has a lot of like cardiac remodeling effects. So I don't know, in your experience, is this a drug that you guys have been using in some of the most severe cases? That's my first question. My other question, you mentioned that pulmonary hypertension was one of the hallmark of some of these babies who ended up dying. And I'm wondering, how did you guys try to tackle the pulmonary hypertension? Was there a non-response to some of the treatment strategies, potentially explaining why they died?
Yeah, so steroids were used only in 2 patients. One is the diaphragmatic hernia baby, but they started steroids mainly because of severe hypotension, but it was, I think, just like an intreatable case, right? And there was another baby that also unfortunately died. This baby had a history of a 10-day antibiotic course. After he was born, he was classified as a congenital pneumonia. Then the baby went home and was infected at home. And when we evaluate that baby, also had moderate pulmonary hypertension, and a lot of lung involvement. So our recommendation was to do basically ventilatory management, but also the attending team started steroids on that baby. That baby, unfortunately, collapsed during the night. It was a really quick thing, so we don't have a follow-up study for that one. But steroids were used only on 2 babies. And all the babies that died had comorbidities, right? We had a bronchopulmonary dysplasia baby, a 26-weeker that we received at 36 weeks of gestation that already had white matter injury, intubated all its life. That baby was on diuretics, sildenafil, and once the baby got COVID, mom asked to enter palliative care and stop intervention. We had a baby with an anomaly pulmonary venous return, a PDA, esophageal atresia, and central nervous system malformation. So all the babies had some baseline diagnosis. In the only cases we recommended management was the case of the diaphragmatic hernia, and the baby with the anomaly pulmonary venous return was in charge of cardiology. But in general, all the babies responded with ventilatory maneuvers, pronation and increase in pressures.
Daniel, can I ask you a question? Shaz, do you mind if I interrupt?
Please do.
Nice to see you, Daniel. I hope you're well.
Nice to see you, Patrick. Thank you.
Okay. So a couple of questions. One from I have one for you. I've got one for Jenny, and Jenny may want to comment as well on the question I asked you. Was there any suggestion that the heart dysfunction that you saw in the very sick babies with pulmonary hypertension, how much of it is primary due to afterload versus could this be myocarditis? And did you look at troponin levels or anything to suggest whether there could be an inflammatory element to the heart dysfunction? And the second question to you is there a role for IVIG? And Jenny may want to comment on that as well in these critically ill patients. And my question for you, Jenny, is the immature newborn that gets COVID, do we know anything about the immune modulator response in terms of the potential of pulmonary vasculitis versus myocarditis in babies? Do we think it's less likely? Or I know it's a tough question, but I'm sure you can give a good response. So those are my questions.
Thank you, Patrick. So regarding direct myocardial damage, unfortunately, as we reconverted several markers that aren't done in the hospital, like troponins, and we weren't able to do those on the babies that we suspected dysfunction. But we only had dysfunction on the congenital diaphragmatic baby that I showed you. All the other babies had, in general, normal ventricular performance. But it has definitely been proposed as a direct mechanism, as that direct injury of the heart. The baby that had an autopsy, they looked for the virus in the heart, and they weren't able to demonstrate it. The baby that mainly behaved as a really inflammatory sort of phenotype was the diaphragmatic hernia baby. But that baby was was a strange case. Mom was negative and all the family was positive. So we assumed that the baby got it at some point very early. So I think you can think about steroids, especially if you start ventilating if you do corrective maneuvers and the baby does not improve. You should start. It's a good idea to consider steroids, and also you need to think about a superimposed infection depending on how long the baby has been in the hospital. And we don't have experience with immunoglobulin. I don't know if Dr. Jennifer has something else.
Yeah. So I think the IVIG question is a really interesting one. And so in COVID in particular, I would see IVIG being useful if a lot of the population had COVID-specific antibodies, right? So that would be the most useful if they were neutralizing antibodies in the IVIG you were giving. But it would depend on the population you were drawing the IVIG from and when it was obtained. So if it was, obtained and stored before COVID was a big thing, you're going to have almost no COVID specific antibodies. If it's more recent, then it'll probably be more useful. I think the Delta variant also throws a bit of a wrench into things. So I think most of us saw almost very few scattered case reports of any neonates with any type of symptomatic COVID prior to the Delta variant. And now that the Delta variant's a major cause of infections, I think both anecdotally at Iowa, and I'm sure other people are seeing more symptomatic neonates. So I think it's a hard question. Do I think IVIG would be helpful in the neonates? Probably not, because we don't really know what's in the IVIG that we're giving them.
Jennifer, I just want to go on with a question maybe for everyone around the panel, because before getting on the line, we were discussing cases that we had also locally since Delta variant became, a thing. And we saw, newborns with severe respiratory ARDS linked to COVID, requiring prone intubation, ventilation, exactly what they're describing on the other side of the fence in the adult wards. And, one of the questions that came up was, I know there are some guidelines and some literature on the use of some of these adjuvant therapies for immunomodulation, like remdesivir and tocilizumab and all of these drugs that I've never used. And I'm wondering if anyone around the panel has any experience in that, and if they've seen any benefits from using these meds in some of these dying newborns.
Yeah, I don't have any experience using them in neonates, and I think the hard part is we have no idea. So I'm not going to pronounce it correctly. Tocilizumab, it targets IL-6, which we don't even know if our neonates with COVID have a lot of it. So is it even going to work in them? And targeting IL-6 is, it's going to cause a lot of other problems if you don't need it. So I don't know. And I don't know that anyone's done a study giving remdesivir, although that would probably be a little less harmful than an IL-6 inhibitor. I don't know. Does anybody else have any experience using it? I have not.
And Jenny, do we know how much of the, again, go back to myocarditis, vasculitis, how much of that is direct virus driven versus some immune driven consequence of the fact that the virus is in you? So do we know if it's primary or secondary?
My guess is it's primary, just based on how other viral myocarditis events work and how we have a lot of things that drive excessive inflammation in neonates that don't cause myocarditis. So I think it's probably virus driven and virus specific. That'd be my guess.
Okay. Yeah, I was just thinking of the Kawasaki type of story. Is it possible that it's something similar to that too? So anyway.
I don't know. Maybe. We need more data. We need to study these kids more. And I think, Daniel, what you showed with your IVH rates and the kids who were positive was really interesting too, because we also had a baby who was 28-ish weeks, 29 weeks, who had a severe IVH that required a reservoir actually. And we don't see that in that age baby at our institution. And so I agree. I wonder if there's a direct effect of COVID, like in utero or perinatal COVID on IVH.
Yeah, I also had that doubt because some of the lesions were not the ones you would expect just for prematurity or the baseline diagnosis.
Yeah.
Hamish, how much have you guys seen in Sinai? Have you seen many cases?
No, not really. We've been lucky in that regard. One of the challenges that our specialty faces from management perspective when we end up seeing a case is also a good thing on the babies, that babies don't get infected that much. It's a very small proportion of patients. And as Daniel said, there are comorbidities associated with them in any way when they actually do poorly. So it becomes very hard to tease out. So it's also a good thing that we don't, and our patients don't end up suffering, but at the sense we can't really develop a degree of experience with any degree of confidence. So I know we in our institutes, from a newborn perspective, we've had positive newborns. None of them have been sick except one patient requiring oxygen. We had one preterm who acquired COVID in hospital. And we only came to know because we were doing a PDA catheter surgery and we were actually did a swab as a part of routine, and the swab came back as positive, and we realized that the mother is also positive but asymptomatic. And then subsequently that patient did actually develop a degree of lung dysfunction, worsened lung dysfunction. We didn't do the catheter, obviously we waited, but ended up going on a ventilator, higher FiO2 needs than before, and also had a thrombus that we noted, that we diagnosed in the IVC, but that all just resolved without any treatment. That's the only real case we have seen.
Yeah, I think, the cases are quite low at each center. We had only a few positive newborns within the NICU locally. But one thing we've seen a lot are obviously mothers coming in with positive, COVID or positive recent history of COVID. And that we see a lot. And, anecdotally, at least we see locally, many of our coolings this year and therapeutic hypothermia cases in our unit have a history of recent COVID infection in the mother. So I don't know if it's because there's so many mothers that are positive when they come into our institution, but it's been very surprising to see a very high level of anecdotally mothers coming in with COVID, and then, they end up with fetal decel, C-section, and the baby has HIE. So I'm wondering if along the panel, there's been a similar sense of seeing a bit more of these therapeutic hypothermia cases from mothers who were recently infected or sick from the virus, or not.
We had one baby that the main diagnosis was asphyxia, but we have a complex health system. So this baby was born in public practice in an institution, was asphyxiated, but then they transferred the baby to a private hospital to receive cooling. They started cooling outside the therapeutic window, but they did the 72 hours. And in between, the baby was positive. That baby had a head scan compatible with this, like near total asphyxia, a really bright head scan, and unfortunately developed multicystic encephalomalacia, and that baby's on follow-up. But it was a really complex thing. To transfer the baby, first they transferred it to a private hospital, and then the baby came to us already with the COVID diagnosis. So, but that's the one we had that was managed as asphyxia. On that baby was on adrenaline. We did the hemodynamic consultation and we stopped the adrenaline because it has good biventricular function.
I mean, we have,
sorry.
I was just saying, I certainly anecdotally have not noticed that association. We've had a lot of positive mothers for sure in Sinai during the peak stage, not so much now. But none of them required newborn to be even admitted to the NICU. Only a couple of them were admitted mainly for low flow type of stage situation, as far as I know. But there could have been a case here and there that I missed.
It sounds like this would be an interesting topic for multiple centers to get together their information. Jennifer, did you have something you want to add?
I was going to say, I haven't seen that association at our center. We've had similar positive mothers, but very few symptomatic neonates.
Well, I'd like to ask there's a couple of questions Q&A I want to make sure to get out. So there's a question that says the subpleural consolidations are larger in some of the infants than what I'm used to seeing. Were those large consolidations found more in the posterior dependent lung zones, and are they larger and more frequently in COVID than what you're used to seeing in other pathologies, such as patients with BPD, RDS? So I know you had mentioned, Daniel, that you do see some more posterior consolidations. Is that pretty much the location that you see them?
Yeah, most of them were posterior. The thing with lung ultrasound and consolidation is that when you're evaluating edema, you and your baby is supine, you can do the anterior and lateral lung. When you want to evaluate the back of the baby, if we were not talking about a COVID baby, we would prompt the baby, maybe scan it, but we normally wait for 1 hour and then scan the baby to properly assess, especially the level of edema. And if some consolidation was a atelectasis, like dependent, normally they disappear. And we follow, when we have a posterior consolidation, we can follow it by time. And normally if it's an atelectasis, it will go away. There's a really interesting study by Deepak Lewis when he did that thing, and he concluded that you need to wait an hour for the anterior and the posterior areas to be equal. Here, as they were COVID babies, we did all the scan at once. We didn't have the time to prone the baby and 1 hour later scan it. But that would be the normal approach. And yes, if you immediately prone a baby, it's possible that you will find a beeline pattern, maybe some white lung if the baby has edema, and you can find some consolidations that they can go away just with time. But yeah, we found more posterior consolidation. Posterior inferior was the main region of consolidation.
Thank you. And one other question, someone commented on seeing a HEPA filter in the presentation slides. Any difficulties with ventilation or ventilator settings encountered?
No, I think most of these babies respond to increased in ventilatory management. We normally develop sort of a people phobia that needs to be combat, but I cannot think about a single case where ventilation was really difficult, just secondary to the COVID infection. The baby with esophageal atresia and anomalous pulmonary venous return, PDA, and an abnormal central nervous system developed a chylothorax in the subsequent study, and we drained that. We drained the chylothorax, and the baby got better. But that was the only extra maneuver we did. But in general, most babies respond with adequate ventilation.
Thank you. And last comments, any additional questions to ask the panel?
Can I ask one thing, Razia?
Please.
Daniel, this is more to do with less to do with COVID, more to do with lung ultrasound. You've been using lung ultrasound quite a lot now, and I see that your experience is sort of increased. My question is more sort of, I also think that it has got a potential value in the NICU setting. My question to you is, where does it go next in terms of its clinical application at the bedside? Because correlating with FiO2 is one thing, but then as Gabriel was talking before, we already have FiO2.
Yeah, so I think really interesting applications that needs to be investigated. Evaluating your ventilation strategies, especially recruiting. That's a really interesting field. There's only a case series of babies being recruited and being guided by lung ultrasound. A lot of people that do lung ultrasound, we have a couple of cases and it normally helps. What I normally do is I start recruiting it, and you hope to pass from a consolidated wide lung to a B pattern and to improve your aeration. The only problem with that is it's difficult to assess hyperinflation. So normally I would do the recruitment maneuvers. I would do the lung ultrasound, but I also do an echo and see the right ventricular output. But I think that like to use it for ventilation is a really interesting application. There's a lot about the utility for extubating. That's also an important thing to investigate. If you can use a certain score using either lung ultrasound and maybe diaphragmatic excursion that gives you confidence to extubate the babies. And well, as you know, there's patterns for RDS, tachypnea, BPD, and also in the BPD population, I wonder if you can at some point evaluate the response to diuretics or steroids, as Gabriel was talking. I think that would be the next thing for lung ultrasound application in the NICU that are really interesting to investigate.
And can I just one follow-up question onto that? Can you distinguish on lung ultrasound with accuracy and with confidence the difference between consolidation versus collapse?
No. No, so if you have a wide lung and you have, some people call that subpleural consolidations, but a more appropriate term might be collapse bronchogram. And you can have a wide lung with collapse bronchogram that surely is a microatelectatic pattern. But when you have a macro pattern, it's really difficult to differentiate between atelectasis and pneumonia. In the adult population, they use the fluid bronchogram as a marker that it's possibly a bacterial infection that needs treatment. But I haven't found that, and it's also reported in the literature that it's not easy. So still, the diagnosis of pneumonia, it's part of a clinical construct. You need to have the clinical data, and also you integrate it with the lung ultrasound, but it's difficult. A lot of times you might have something that you swear it's a pneumonia, and you wait a little bit of time, you do some positioning, and it disappears. So it needs to be evaluated with time.
Right. A bit like X-ray, and Daniel, when you see a sometimes you're not sure if it's atelectasis or if it's actually an underlying infection.
Yeah.
Thank you, everyone, for being here today. I really appreciate this talk, and Daniel for kicking us off for site presentations. And thanks to Gabriel and Jennifer for being on, and Amish and Patrick, of course. Please tune in for our next one. Will be in January, and if any sites are interested in presenting, please do let us know, and we'll get topics and all that together. So thank you all, and hope you have a good afternoon.
Thank you.
Thanks, guys. Yeah, well done.
Well done, Daniel.
Good job, Daniel. Fantastic.
Thank you.
Daniel.
Thanks, Daniel.
And thanks, Laura, for putting also